Everyone, welcome to the day 2 of Surgery Visual Fest round 2. So today let us continue from the place where we have left. So let us start with the good questions. These image based questions, and the purpose behind discussing them is just to get you the best concepts of surgery related to the images, because images are really very important for all of your exam. So let us, without wasting time, let us start with this today's session. Okay, so the first question, this is going to be a bit, you can say, tough question for you, but it's a very important thing. Identify the structures marked in this image. So first of all, what are the things that you are seeing in front of you? Just a minute. Okay, so what are the things that you are seeing in front of you? Sir, I am looking at something which is liver right now. Second is, this is the gallbladder, and this is again the surface of the liver. So what are the important things that I am looking at? The structure which is marked as this structure A, what is this structure? So identify the text A and B, what is written. So remember, this is what is known as Rouvier's sulcus. So whenever we talk about Rouvier's sulcus, it may be an open type, it may be a split type, it may be a closed type. So this is an open Rouvier's sulcus, which is the most important crucial landmark before we start with the dissection of the critical window of safety. The second is the structure which is labeled as B. So basically this is a line which we are talking, and this line is known as R4U line. Dear students, बहुत important है, बहुत ज़्यादा important है, ये आपको कोई निमोनिक बना के रटवा नहीं सकता, ये उनकी मान मर्यादा के beyond है. So when we talk about what is R4U line, remember the R4U line is the base of the, remember the base of the Rouvier's sulcus. So this is a line from the base of Rouvier's sulcus, point number 1. The second is, then the second point that we have is the caudate lobe, that is quadrate lobe, segment 4. So segment 4, the upper limit, upper border of the segment 4. So the upper border of segment 4, the base of the Rouvier's sulcus, and here you have a fissure which is known as umbilical fissure. So umbilical fissure, segment 4 and Rouvier's sulcus, they together form a line which is known as R4U line. And remember, without understanding the location of this line, you cannot start with the dissection. So what is the significant things, or what are the important things that we need to understand with respect to this? So the question is, answer all the following, what are all except are false with respect to this line. The first is, cystic duct is dorsal to this line. Students, why is this line important? Always understand, above this line we have to stay. Remember, above this line. So when you're doing lap cholecystectomy, this line is of paramount importance. Why this is of paramount importance? Try to understand something like this. So this is how the structures are. This is how the structures are. When we talk about the R4U line, the R4U line is something like this. If you do the dissection below, so dorsal to this line, you have the CBD, this is important, and ventral to this line, you have the cystic duct and the cystic structure. So the very first mistake with surgeons who don't know about this R4U line is that they start opening the calots. So posterior window of safety, and what is this posterior window of safety, better known as posterior window of safety का दूसरा नाम होता है cholecystohepatic triangle. It is not the Calots triangle, cholecystohepatic triangle. So the rule number 1 is, we always need to stay ventral to this line, because ventral to this line we have the cystic structures. If you go dorsal to this line, बच्चे injury of CBD होनी ही होनी है. So cystic duct is dorsal to the line, absolutely false. CBD is dorsal to the line, absolutely true. Surgical dissection should be done below this line, no, above this line, to avoid the dangerous injuries that can happen. So कल मैंने एक biliary injury पे आपको पढ़ाया था. And so what is the answer? Answer is B. Let me tell you again, for those who are still confused, what is cholecystohepatic triangle? What is a cholecystohepatic triangle? If you see, this is how the liver is. This is the inferior surface of the liver, and this is how the hepatic duct is. So the triangle which is formed in between the liver, the gallbladder and the cystic duct and the common hepatic duct. This triangle is known as cholecystohepatic triangle. So when we talk about cholecystohepatic triangles, what are the borders? It is the inferior surface of the liver, it is the common hepatic duct, and it is the gallbladder, along with that a part of cystic duct. This is what is cholecystohepatic. अगर आपसे कोई कहता है कि then what is Kellogg's triangle? This triangle is Kellogg's triangle. So what is the boundary of Kellogg's triangle? Cystic duct, cystic artery and common hepatic duct. This is what is Kellogg's triangle. So without wasting time, let us go to the very next question. A patient presents to ER with sudden severe hematemesis. So sudden severe hematemesis. He has a long standing history of alcohol intake with chronic liver disease. So it's a very easy question. Following intervention has been done. So now you can understand this is upper GI bleed. One very important thing is this is upper GI bleed, and this upper GI bleed is associated with portal hypertension. Very simple, very important thing. Now what has been done for this patient? So this is the this is the image of the procedure which has been done. So what is this black instrument? That's an endoscope, and then with a, you can say, with a grasper, with a modified ring grasper, you are grasping the what? The varices, and then on this varices you are going to slide down the, you can say, the band. So this is what is known as EVL, or endoscopic variceal ligation. So this is an image of endoscopic variceal ligation. अगर यहाँ पर कोई needle होती, so that would be known as the sclerotherapy. This is not a balloon tamponade, because balloon tamponade there would be a balloon with two chambers. One is the esophageal chamber, one is the gastric chamber. And what is this BRTO? This is known as balloon retrograde ट्रांसआर्टेरियल ऑक्लूजन. अब क्वेश्चन आता है कि सर इसका नाम आपने यहाँ पर क्यों रखा? रिमेंबर स्टूडेंट्स, व्हेन वी टॉक अबाउट BRTO, वी actually catheterize the vessel and we occlude that vessel. What is the significance of BRTO? Do we do it for portal hypertension? Yes, we do it for portal hypertension. But if it is the gastric varices, but if it is gastroesophageal varices, for them we are going to go for either the band ligation or we are going to go for endoscopic sclerotherapy. Just in a nutshell, we shall be seeing this thing. A patient presents to you with upper GI bleed, and when the patient presents to you with upper GI bleed due to portal hypertension, the very first thing that you have to do is that secure ABC, airway, breathing, circulation. ये सबसे पहले secure करना है. The very next thing is, along with that, you have to give IV PPIs. Why IV PPIs? Because they will reduce the chances of what? The gastritis induced, you can say, recurrent bleeds. Along with that, you have to start with antibiotics. This is again very important. And along with that, you have to start with octreotide. This is the simplest, you can say, approach that we have to go for. Once and along with that, always start with the resuscitation. You have started with the resuscitation. Once the patient is hemodynamically stable, within 12 to 24 hours, more than 12, but within 24 hours, you have to go for early upper GI endoscopy. There is no added advantage if you go for endoscopy within that phase. Now the very next thing is, when you go for upper GI endoscopy, the next thing is, what is the location of the bleeders? So there are two important things. It could be the GE junction, it could be the gastroesophageal, you can say gastroesophageal varices, point number one, or it could be isolated gastric varices type 1. What is the isolated gastric varices type 1? We mean that they are at the level of fundus or proximal stomach. If it is isolated gastric varices type 2, that means anywhere other than the, you can say, other than the fundus, for that patients we have to go for TIPS. This is important. Or you can go for BRTO. For them, the endoscopic variceal ligation is of minimal use. So if it is, I'm talking about if there is ongoing bleeding. If the bleeding has stopped, then that is okay. So if there is ongoing bleeding, you will have to go for this intervention. Suppose you went for GE junction, or you can say gastroesophageal varices or IGV, isolated gastric varices type 1, for them you have to go for EVL or you have to go for injection sclerotherapy. This is one very simple thing, but if it fails, then in that case you will have to go for the balloon tamponade, or if that also fails you have to go for TIPS. This is how we go for. In this case, if it fails, you can also go for devascularization surgery. When we talk about devascularization surgery, we have Sugiura. So we have a Sugiura procedure where we actually devascularize majority of the lesser curvature, complete greater curvature, distal 7 centimeter of the esophagus also, and along with that parietal vagotomy, that is highly selective vagotomy. Nowadays there is one more thing that is known as स्प्लीनोन्यूमोपेक्सी. नाउ ये बहुत इंपॉर्टेंट है क्योंकि ये आधे से ज़्यादा लोगों को नहीं पता है कि what are the different devascularization procedures. So एक तो होता है Sugiura और एक होता है splenoneumopexy. What is splenoneumopexy? This is done whenever you have the extrahepatic portal vein obstruction. For extrahepatic portal vein obstruction with uncontrolled bleed, whenever you have such type of, you can say, scenario, in that case you will fuse the spleen with the lung. So I will share one image here so that you have a better idea of this classical surgery that I am going to show, because it's a very complicated procedure. Not a lot of you will understand simply by looking at this. So I will share the image of both of these surgeries. So बच्चे आपको ये समझ में आना चाहिए कि what is this? This is a devascularization surgery where you also go for splenectomy. और यहाँ पर क्या करोगे? You will fuse the lung with the spleen, and this is what is known as splenoneumopexy. Can you see? Diaphragm, spleen, lung. This is how you control, and this is done whenever you have the total mesenteric obstruction. So basically this is done for mesenteric obstruction when the cause is not in the lung, cause is not in the liver. So mesenteric obstruction cases you have to go for splenoneumopexy. Let us get back and go to the next image. So let us see this. Following is the cut section of the specimen of benign liver tumor. So written tutor, it's liver tumor. Yeah, all except are false with respect to this. So we need to find the correct one. Remember, yes, it is a benign, but it could have a benign, tumors can have a malignant potential. So looking at this specimen, can you identify? Bache, try to understand. This is a cut section. On the cut section, a very significant thing that you can see is a central stellate scar. So this central stellate scar, and along with that you have the HPE finding. बच्चे हिस्टोपैथोलॉजी मैं सर्जिकल पॉइंट ऑफ व्यू से कोई भी ऐसी चीज़ नहीं पढ़ाऊंगा जो मैं आइडेंटिफाई ना कर सकूं, बट यू कैन सी a lot of bile duct elements are seen in this image. Lot of bile duct elements are seen. There are Kupffer cells. There is an intense hepatocyte Kupffer cells, normal looking hepatocytes and Kupffer cells. So basically this is looking like a normal thing with a central, you can say, with a, if you see, this is a central arteriole. So यहाँ से हम अंदाज़ा लगाते हैं कि there is a central stellate scar. On pathology also we see a lot of normal hepatocytes with Kupffer cells, and this is therefore suggestive of FNH. What is FNH? This is focal nodular hyperplasia. So first of all you should understand why it is critical to identify focal nodular hyperplasia, because it's a 100% benign lesion. So क्या इसमें significant potential of malignancy है? No. Unlike this, we have hepatic adenoma, which is a benign tumor, but it has an adenoma to carcinoma sequencing. So yes, if it would have been an hepatic adenoma, यहाँ पर ये चीज़ होती है. How to differentiate between hepatic adenoma and this on cut section? बच्चे पहली बात तो देर विल बी नो स्टीलेट स्कार इन हेपाटिक एडिनोमा. अगर यहाँ देखोगे सो यू विल गेट टू सी लॉन्ग फेसाइकल्स और स्पिंडल्स ऑफ द हिपैटोसाइट्स with the oil or fat globules. This is what is very important. Kupffer cells यहाँ पर नहीं देखने को मिलेंगे. No central dilated arteriole. So when we talk about this, the very next 5 important points that we need to understand about the concept of hepatic, you can say focal nodular hyperplasia. And with this I will also give few important tips about how to differentiate focal nodular hyperplasia from this hepatic adenoma. So when we talk about focal nodular hyperplasia, it is nothing but a dilated abnormal central arteriole. ये abnormal vessel है, and around the abnormal vessel there are millions and millions of hepatocytes. And do you know, this is just like, try to understand a normal liver nodule. Why it is looking like a nodule? Because there has been cohesive clumping of lot of hepatocytes. Now when try to understand, this is like a rock star concert. So जब भी बहुत एक बड़ा सेलिब्रिटी आ रहा होता है, so there will always be a crowd, and whenever there is a crowd you can always think of something can happen. So you always deploy the police person, and that is why, since there are a lot of hepatocytes, so there will be Kupffer cells. So this is a nodule, and this nodule contains normal hepatocyte, point number 1, and along with that the normal Kupffer cells. ये दोनों चीज़ें बहुत important हैं. The second important thing is that they are purely benign. There is no association with the OCP. Yes, they are female predominant. Very important thing is on HPE, you get to see certain important things. What is that? The bile duct elements are present here, and the portal venous elements are absent here. So portal venous elements, they are absent, bile duct elements are present. अभी आप क्वेश्चन देखोगे उल्टा लिखा हुआ है. The next is we have a central stellate scar. This is really very important. So ये 3 points याद रखना, हमेशा के लिए खुश रहोगे. Now try to understand, since it's a nodule, we need to differentiate it from the HCCs. Yes or no? Because अगर liver में nodule है, the first thing that you get to see is like, could it be a malignancy? So that is the reason we go for triple phase CT. So when we talk about the triple phase CT, what are the 3 important things? Bachche, the first phase is non-contrast. So there is non-contrast. The second is we have the early arterial, and we have the delayed venous phase. So when we talk about the non-contrast, what kind of attenuation you are going to get? Sir, isme there are normal hepatocytes, and since hepatocytes are there, therefore you will get to see isoattenuation. Lot of small capillaries are there, so they are getting the blood. So because of the blood filled inside the capillaries, you are going to get to see hyperattenuation. And then when you actually give the contrast in a short span of time, the entire nodule which is having a lot of capillaries, there is homogeneous enhancement. And when we talk about homogeneous enhancement, one very important thing is this abnormal arteriole is left except the scar. So scar uptake is not seen, but in the late phase, yes, there will be scar uptake also. So scar uptake is there, and that is how you decide that it is hepatic adenoma. One very important thing is how you decide that it is FNH. One very important thing is how to differentiate between hepatic adenoma versus FNH. Why? Because there is something which is known as atypical FNH versus atypical FNH. ये 3 चीज़ें याद रखना. When we talk about atypical FNH versus normal FNH, the first thing is central stellate scar. So central scar, this is absent in adenoma, present in FNH, is absent in atypical FNH. बड़ी important सी चीज़ है. Second is when we talk about the bile duct elements, these bile duct elements are absent in hepatic adenoma, present in FNH, but absent in atypical FNH again. Then when we talk about portal venous elements, remember they are present in the hepatic adenoma but absent in the FNH. Remember they are present in atypical FNH. Then that is what is really very problem. When we talk about the Kupffer cells, now this is where you get to steal the show. So Kupffer cells are absent in the hepatic adenoma but present in both of them. ये सबसे important चीज़ है, समझने की कोशिश करना. Then when we talk about the nature, remember everyone is benign, But yes, this is a benign with what potential? With malignant potential. This is really important. So how do you differentiate? So we go for MRI with sulfur colloid scan. So MRI with sulfur colloid scan, and this sulfur colloid scan, this is sensitive for the Kupffer cells, and this will show you a hot bulb sign or a hot spot sign for the FNH, and it is negative for hepatic adenoma. बच्चे अगर क्वेश्चन में ये नहीं लिखा होता, so there is MRI with SPIO dye. When we talk about SPIO dye, this is super permanganate and iron oxide. So super permanganate iron oxide, this is positive with a hot bulb sign for FNH and negative for hepatic adenoma. So this is what, because you don't require any dissection for them, this is the most important thing to identify, differentiate. So lot on FNH, lot on hepatic adenoma. You can go to my routine lectures in Surgery Dada. There I have explained that hepatic adenoma, what are the three types: inflammatory type, telangiectatic type, then we have the beta catenin variety, all those things, HNF1 alpha type. So it's not wise to discuss everything here. Let us go and discuss one more question. Okay, the patient presents to you with recurrent regurgitation and reflux. The endoscopy reveals the following image. Now why I am asking this image? Because आपके एग्जाम में this has been asked many a times. बच्चे, a patient with, you can say, recurrent reflux, and when you went for the upper GI endoscopy, you get to see stack of coins, or you can say, or a feline esophagus. So feline esophagus or stack of coin, this is what is indicative of eosinophilic. This is really very important. So eosinophilic esophagitis. So what is this diagnostic of? Eosinophilic esophagitis. So this is feline esophagus. More important cause is eosinophilic esophagitis. It may be also seen in GERD. So diagnosis approach, I've already told you. The management, when we talk about the first line is the medical management. And what is the medical management? You have to go for topical steroids. So topical steroid is the classical management that we have, and along with that we'll also go for antihistaminics. Surgery is not done for the feline esophagus in the early stage. So feline esophagus or eosinophilic esophagitis. Let us understand more important questions. Let us understand. Now, a patient presents to you with pain over the anterior chest wall. समझने की कोशिश करना बच्चे. Already I have taught this topic in great depth in my lectures. Both the series for the NEET PG, or if you have taken दादागिरी series 1, दोनों में मैंने बड़े अच्छे से समझाया इसको. So this pain over the anterior chest wall with radiation towards the scapula. ये इस kind की image, the image shows you something. So what is this suggestive of? बच्चे, this is dissection. This is a classical image showing you aortic dissection. So identify the type of aortic dissection that we have. Generally, aortic dissection is seen in the thoracic aorta. So this is a thoracic aortic dissection, and if you see, this is the left subclavian. So distal to the left subclavian you have the descending thoracic aorta, and when we talk about descending thoracic aortic dissection, this is either a DeBakey or we call a Stanford. So DeBakey type 3B or a Stanford type B. So let us understand what is DeBakey, what is Stanford, दोनों ही समझना बहुत ज़रूरी है. So let us understand in nutshell what are the various type of thoracic aortic dissection. So whenever we talk about thoracic aortic dissection, what are the must know things about thoracic aortic dissection? The first very important thing is what is the type. So we have a classification. I hope you know what is aortic dissection. When the blood enters in between the any two layers, and will cause a laminar separation. So between the, you can say, in the vessel you have two lumens. What are the two lumens? There is something like this. So imagine if the blood has entered via this port, and thus this is a true lumen and this is a pseudo lumen. So we have the pseudo lumen and we have the true lumen. Let us try to understand what is the classification for them. Whenever we talk about the classification of aortic dissection, the aortic dissection has three different kinds of classification. So aortic dissection based on the chronicity. So when we talk about the chronicity or the duration, we have it in form of acute. What do you mean by acute? Less than 14 days history. Then we have subacute. What do you mean by subacute? More than equal to 14 days, that is more than 14 days, that is 15 days to 60 days. बच्चे पहला जो क्लासिफिकेशन था वो कहता था अक्यूट और क्रॉनिक, 14 दिन के बाद क्रॉनिक. अभी 14 डेज अप टू 14 डेज इट इज अक्यूट, मोर देन 14 that is 15 to 60 it is subacute, and then we have chronic. Remember, chronic more than 60 days. The second classification that we have to understand is based on the direction of dissection. When we talk about direction of dissection, what do you mean by direction of the dissection? Mostly it is antegrade. So antegrade is the most common type. More than 90% cases it is antegrade, and sometimes it is retrograde. What is retrograde? That means 10% of the patients it is towards the heart. So it is starting at the level of maybe right subclavian and going up to, or maybe starting at the level of right innominate and going up to the heart. So towards the heart, this is what is the retrograde. And third is on the basis of the location. So when we talk about the location, the two important locations that we have is, where is it located? According we have two important classifications. So we have a Stanford and we have a D Bakey's classification. बहुत important है स्टूडेंट्स. डे स्टूडेंट्स, आपके लिए ये सारी चीज़ें इंपॉर्टेंट नहीं, बहुत ज़्यादा इंपॉर्टेंट है. आप हमेशा कंफ्यूज रहते हो between dissection and the aneurysms. So when we talk about the Stanford versus the D Bakey's, समझने की कोशिश करना. This is very simple. Imagine this is the heart. So this is how the things are. So this is the heart. This is the right innominate. This is the right common. This is the left common carotid, and this is the left subclavian artery. So if there is a dissection, like this, it is located in the ascending aorta. If it is located and confined to the ascending or arch, that is what is known as Stanford A. So what is Stanford A? It is into the ascending thoracic aorta. So if the dissection is into the ascending thoracic aorta, that is known as Stanford A. Bachche, what is Stanford B? When we talk about any dissection which is located distal to the left subclavian, so this is along the descending thoracic aorta. So descending thoracic aortic dissection, this is what is known as Stanford B. So Stanford A, Stanford B. Now when we talk about the D Bakey, now D Bakey is very interesting. So D Bakey again is known for a lot of interventions that he has, or his contribution to the CTVS surgeries. In fact, the D Bakey forceps is very important. When we talk about the D Bakey, remember D Bakey is type 1, type 2 and type 3. What is type 1? Type 1 involves, there are many aortic dissections which start at the level of ascending aorta, ascending thoracic aorta, may go up to the descending. So it involves both. What do you mean by both? It involves ascending plus descending thoracic aorta. This is what is the type 1. What is type 2? It involves only ascending thoracic aorta. So then that is known as type 2. So ascending thoracic aorta or the arch. What is type 3? It involves the descending thoracic aorta. Now if we see it in image, it would be something like this. So what is the type A? the type A, this is the type A. So it is involving the ascending also, it is involving the, you can say, descending. According to Stanford it is type A, but according to DeBakey it will be type 1. So Stanford type A, this is a DeBakey's type 1. What is DeBakey's type 2? Remember, suppose if this is involving only the ascending, so this will be DeBakey type 2 or again Stanford type A. Now imagine the third variety which you are seeing in your image also. This is the left subclavian artery, and if there is a dissection involving this. So you all know that the aorta, that is descending aorta, will continue as the abdominal aorta. Now try to understand, there is something which is known as 3A. What is 3A? When it involves only descending thoracic aorta. Remember, sometimes the dissection may continue down right up to the abdominal, below the diaphragm into the abdominal aorta. It may go right up to the bifurcation of aorta also. So what is this known as? This is known as 3B. What is DeBakey's 3B? It involves the descending thoracic aorta. So descending thoracic aorta, dissection extending to the abdominal aorta. So this is what is really very important. So 3A 3B में फर्क समझ में आ गया. So the first is we are to identify this, what type it is. Can you see it is above the diaphragm level only? So if it is above the diaphragm level, so it will be DeBakey type 3A or Stanford type B. दोनों में से एक चीज. Then what is the investigation of choice? Now this patient arrives with context to this question. This patient arrives to the ER in the emergency state. So patient is hemodynamically unstable. So quickly let us understand what is the classical approach to aortic dissection. But 90% of the faculties don't even teach this part. वो कहते हैं बस ये DeBakey याद रखना, this and that, and that's it. बच्चे अब तो असलियत आए, अब तो main चीज आई है, the management. So whenever you have a patient of aortic dissection, if you still want to develop the concept, join Surgery Dada, visit this routine, visit my routine lectures and study this topic. I have at least given more than 1 hour to this topic. Aortic dissection का जब भी patient आपके पास आएगा, the first thing is you have to stabilize two things. You have to stabilize the pressure, which is going to cause an impending rupture, and along with that you have to stabilize rate and rhythm of the patient. Once you stabilize rate and rhythm and the pressure, the very next thing is what is the hemodynamically, what is the status of the patient. There could be two things, the patient is unstable, the second is the patient is stable. बच्चे अगर patient unstable है, so you cannot take that patient for a conventional CT. So for unstable you will go for TEE. So what is the investigation of choice for unstable patient? Transesophageal echocardiogram. So this is really very important. So transesophageal echocardiogram. On this transesophageal echocardiogram, check what type it is. If it is a Stanford A, plan intervention, plan surgical intervention. This is really very important. If it is a Stanford type B, then remember Stanford type B or DeBakey type 3, then you will have to go for conservative management in this case. Type 3B virtually has no treatment. When we talk about the stable patients, you will go for CET. Remember, if CET, if the diagnosis is confirmed, then you have to ask what is the type. Bachche, if the diagnosis is still doubtful, then you will have to go for CT angio is the investigation of choice. Remember, you directly don't go for CT angio. CT angio is the investigation of choice. If the CT angio is diagnostic, you will ask what is the type. If this is still doubtful, remember, consider alternate diagnosis. So CT or MR angio, if it is doubtful, बच्चे consider alternate diagnosis. So if it is doubtful, you can also go for TEE, or if you want to have the best, then you go for the CT angio. कई बार CT angio doubtful होता है, एक बार TEE करा लो, नहीं मिलता है, then consider anything else. Again, what type it is? If it is a DeBakey 1, DeBakey 2, yes, you have to go for surgical intervention. But if it is the DeBakey type 3, then you will have to go for conservative management. In the ICU, you might control the pressure, prevent it from ruptures. This is what is the complete management. So we have seen lot of things associated with this. Again, very famous question. I have been teaching this question, this image for a very long time. हर साल कोई ना कोई, every year 1 or 2 exams you get this image. So following is a maneuver done for left retroperitoneal axis. बच्चे, try to understand. If we see the abdomen, you know the peritoneal cavity is separated from the retroperitoneal cavity. So if we see, this is how the colon is, and therefore we need to mobilize the colon in lot of cases. So we have to do the colonic mobilization. And how we do the colonic mobilization? Understand that there are peritoneal fringes which separates the peritoneal cavity from the retroperitoneal cavity. But what are these fringes known as? These are known as the fold of, or you can say the white line of Told or peritoneal folds. So what is the white line of Told? White line of Told, or you can say the Told's fascia. These white line of Tolds are nothing but the peritoneal attachments. So if I want to enter into the right side of the retroperitoneum, I will have to shift the viscera towards the left, and that is what is known as cattle-brash maneuver. So what is a cattle-brash maneuver? When you mobilize the right-sided colon towards the left, this is known as cattle-brash. Now in this case, you are dividing the white line of Todd and entering into the right retroperitoneum. So remember, division of white line of Todd along the left to enter into the right side, left side. So this is known as Mattox maneuver. So बच्चे, Mattox किस साइड के लिए होता है? लेफ्ट साइड के लिए. क्वेश्चन कैसे आता है? आप कंफ्यूज होते हो. राइट मीडियल रोटेशन और राइट विसरल रोटेशन, इट इज नॉट राइट साइडेड विसरल. So I will rotate the viscera of the left side towards the right, then that is known as a Mattox. Right-sided visceral rotation towards the left, entering into the right retroperitoneum, that is what is known as cattle-brash. So बच्चे, यहाँ पर क्या? This is the site and this is the viscera that you have, you can say, mobilized. So cattle-brash versus Mattox, is this clear? Remember, if you want to go behind the, you can say you want to do a surgery of the kidney, so you will have to, or you want to operate on a pancreatic head, so you will have to do the mobilization of the duodenum. So if you do the mobilization of the duodenum, you will have to divide these peritoneal fringes around this. And what is this known as? This is known as cauterization. So what is cauterization? It is the mobilization of the duodenum, by division of peritoneal folds around this. So तीन चीजें याद रखना. कैटल ब्रैश किस साइड के लिए? राइट रेट्रोपेरिटोनियम. लेफ्ट साइड के लिए क्या? मेटॉक्स. एंड इफ यू वांट टू मोबिलाइज द डियोडनम, दैट इज व्हाट इज नोन एज कॉकराइजेशन. वेरी 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 इंपॉर्टेंट. सो following is the grading for the renal trauma. So I have given you the grading in the image. Answer the, you can say, following with respect to. So what is the investigation that we do, how we approach, and what is the management? Again, students, no exam is complete without the renal trauma being asked in your exams. So बच्चे, renal trauma is very 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 important. Let us try to understand the concept of renal trauma. Whenever we understand about renal trauma, इसकी grading कैसे होती है? The grading is very simple. Lot of you have to mug up. बच्चे, mug up करने की ज़रूरत नहीं है, बड़ा easy सा है. It is very 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 easy. So what is the grading of this? Understand. The first is, the grade 1 is hematuria. So grade 1 is hematuria, point number 1. Macroscopic हो, microscopic हो, that is a different thing. The second thing that we have is, what is grade 2? So grade 2 is defined as the classic or subcapsular hematoma. So subcapsular hematoma or hematuria. The second thing that we need to understand is, what about grade 2? What is grade 2, students? Grade 2 is defined as laceration less than 1 centimeter. So laceration less than 1 centimeter is your grade 2, or non-expanding perirenal hematoma. Very important. स्टेजिंग आपसे पूछते ही पूछते हैं हर साल कुछ ना कुछ. ग्रेड 3 इज लैसरेशन मोर देन 1 सेंटीमीटर इनटू द किडनी. नाउ इमेजिन अगर दिस इज अ डीप लैसरेशन, you will be expecting that blood shall come, but in case if the urine leaks, so this is very important, without urine leak. So if the urine leaks, then that will be known as at least a grade 4, because collecting duct injury is there. So grade 4 is defined as a urine leak, any laceration extending into the collecting duct. So if it is extending into the collecting duct, definitely there will be what? Urinoma. So ये question कई बार पूछा जाएगा urinoma. Or expanding perirenal hematomas. So expanding perirenal hematoma will be considered as grade 4. And what is grade 5? Shattered kidney. So shattered kidney or hilum injury. Now the question number 1 with respect to this, what is the investigation of choice? So whenever we have a patient of renal injury, the very next thing that we need to understand is, what is the nature of the injury? Is it blunt or is it penetrating? Because if it is penetrating renal injury, that's a retroperitoneal zone 2 injury, you will have to go for surgery. If it is a blunt trauma, the very next thing that you need to understand is, what is the status of the patient. Now there could be two things: the patient is hemodynamically stable, the patient is hemodynamically unstable. Now unstable, the patient is, you will take the patient to OT. Remember, you will take the patient to OT and there you will inject urographin, place the patient on the OT table, लेकिन OT नहीं करोगे, do a C-arm assessment. So what are you going? You are doing, if you are injecting a drug, what is this? This is IVU, intravenous urography. So इसको कहते हैं single shot IVU, because you need to be confirmed, because once you release the retroperitoneal tamponade effect, it will never come back. So single shot IVU with 10 minutes delay film. Why 10 minutes delay film? Because बच्चे, once you inject the urographin, it will take some time to be excreted. So this will tell, अगर suppose contrast आया ही नहीं उस किडनी में, मतलब उस साइड में कोई vascularity नहीं है, contrast आया but it is extravasating out, that means it confirms an injury. So yes, on this, if the injury is there, if the injury is plus, proceed for the surgery. So मतलब patient को OT ले गए, उसका मतलब ये नहीं कि नहीं अब तो मैं ऑपरेट करके ही निकलूंगा. So proceed for surgery and repair. Remember, if there is no injury, then transfer the patient to ward and go for conservative management. If the patient is stable on the other side, you will have to go for CT scan. So CET with 10 minutes delay film. Now why this 10 minutes delay now? Remember, suppose you click a CT and right now the CT is showing you an injury like this with some hematoma here. You can say this is a perirenal hematoma, but to comment whether it is an expanding or no, you will again have to wait and recompare it. So suppose this is at 20 seconds and then after 10 minutes, suppose let me show this image. So after 10 minutes we saw this very same image like this. So after 10 minutes, can you see the same hematoma which was falling into a category 2 versus 4? It is confirmed that this hematoma is what? Expanding. So after 10 minutes, you get to see the dynamics of the contrast, and therefore this investigation is known as DCCT. What do you mean by DCCT? Dynamic contrast CT scan. And on DCCT, yes students, you will check whether or no there is injury. If yes, there is injury, then you need to understand what is the grade of that injury, because if it is grade 1, grade 2, grade 3, then observation is the call. If it is grade 4 and 5, then surgery is the call. When you talk about what surgery are we going for, then that depends upon what level of kidney has been left over. So renal function will be decided according to that. If it is 20% functional kidney, you will have to go for total nephrectomy. Why? Because less than 20% will not suffice. Minimum functional residue of the kidney that we require should be at least more than 20%. If it is more than 20%, always appear you can say try to go for rhinography. So rhinography is preferred over partial nephrectomy. So this is all that we need to understand about the renal trauma. Let us come back. I'll discuss these images again. So what is this incision shown? So what is this incision shown in this image? A patient has undergone a breast surgery, and breast surgery for what? Fibroadenoma. So all of you know that for fibroadenoma, which falls into the benign disease, the surgery will be done only when the patient is, you can say, very confident, okay, the doctor operate, because most of the females are reluctant for the surgery because they think that scar, and breast is not only organ of lactation, it's an organ of cosmesis. So females generally avoid, they are reluctant towards surgery. So you have to explain, no madam, the incision that we will be giving will be cosmetically acceptable. A cosmetically acceptable incision could be around two things. So this is the nipple areolar complex. So either you can make the incision around this, but here it is not. If you make the incision around this is known as circumareolar incision, and circumareolar incision, this is also known as Webster's incision. बच्चे दूसरा incision होता है, why you give it around the nipple areolar complex? So that you can hide it. The second incision is you can give the incision along the inferior mammary crease, and this is what is known as inframammary incision. And when we talk about inframammary incision, what is this incision better known as? This is known as Gallard-Thomas incision. So these are the incisions that we make for the benign cases. Remember, when we talk about the benign breast diseases, cosmesis is of paramount importance. So this is the circumareolar incision, and this is the inframammary incision or Gallard-Thomas incision. This is Webster's. Webster's एक जगह और याद रखना, Webster's flap is used for, answer is lip reconstruction for defects which is more than 1/3 but less than 2/3. Webster's, this is Webster's flap. We have Webster's incision. अभी ये दो incision और लिखे हैं, Stewart incision and Orr incision. So let us quickly understand how we plan the incisions for the breast diseases. So whenever we talk about the incision for the breast, the very next thing that we need to understand is what is the indication. The second thing that we need to decide is, sir, it is a benign breast disease or this is for the purpose of malignancy. So whenever we are talking for a benign breast disease, the purpose of this incision has to be defined. The purpose is to maintain the cosmesis, and here the purpose of the incision is maximize the clearance. To maximize the clearance, the incision should be what? Wide, irrespective of where you are putting. So whenever we talk about the cosmesis, there are two contours which we prefer. Circumareolar, I have already described circumareolar or Webster's, and the second one is the inframammary, or you can say the Gallard-Thomas. These are the incisions which we have already seen. But when we talk about the maximization of the clearance, then the incision nature is elliptical incisions. So when we talk about the elliptical incision, we have two types of elliptical incision. We have the elliptical transverse. This incision is also known as a Stewart's incision, or we have the elliptical oblique incision. What is this oblique incision, better known as Orr? Now where do we indicate this incision? Remember, this is suppose the tumor. The incision are extending from the medial to lateral border and they are going into the axilla. So the same incision will lead you to axilla. This is transverse elliptical. Remember, if the tumor is in the upper outer quadrant, in that case you will have to plan an elliptical oblique incision extending into. So O for oblique, O for Orr, and O for the outer quadrant. So this is how we plan elliptical incision. Students, this is all for the day. I hope you're enjoying. Do recommend Surgery Dada to your friends. If you have still not joined Surgery Dada's regular courses, do check out. They are the most precise courses. At Surgery Dada, you get complete one-stop solution to the surgical needs. We have training programs. We have the course for the MBBS students, the course for the NEET PG and INSET resident students. Then we have an exclusive course, that is Dadagiri Series 1. For the surgery residents and NEET SS. So we have a lot of things. Do check out my books. They are question and answer based, they are clinical concept based, and then we have the synopsis of my notes. So till then, bye bye. I hope you are enjoying this session.